What about population health surveys? I'm changing here. You go, well, what's vitamin D good for other than bone? And there's a very nice meta-analysis of meta-analyses. And the purpose of this particular slide is just simply to summarize, in cross-sectional health surveys, a meta-analysis is comparing rates of disease in the high vitamin D group versus the low vitamin D group. And basically this graph, if there were no difference, the confidence interval lines would not cross this 1 ratio. That vertical line represents 1. The highlighted line indicates 0.5. In other words, for this particular study related to prostate cancer occurrence, higher vitamin D group had less prostate cancer. And you can look, there's cardiovascular disease, depression, diabetes, fracture rates, and not exactly mortality, but there's a variety of diseases in which vitamin D does benefit. Problem, if you present this, people go, that's a population survey, it's useless. Give me please level 1 evidence. You know, in medicine, level evidence is taken from level 1 down to circumstantial, which is like level 3. You know, you may have opinion, cohort, you've got randomized trials, systemic reviews of randomized trials, etc. So people demand, policymakers demand the utmost in evidence, okay? But I want to get to the concept that demanding the most evidence is not realistic. For example, if you had a drug clinical trial, you'll have a placebo group, you'll have a treatment group. You will choose people who are at high risk of disease. In other words, you'll take, people who've had a heart attack, put them on a drug, and see subsequently whether placebo has more events than your dose. Or you'll get osteoporosis patients with a fracture, and you'll look subsequently whether your new drug reduces fracture rates or falls or some outcome, right? So you're selecting people for existing conditions that are highly motivated to take your drug. You're going to follow them up for no more than 5 years because a graduate student wants to be done in 5 years, right? And you're going to look for high likelihood of event. What about nutrition studies? Nutrients. Okay, if you compare a drug study like this, you got placebo and dose. With a nutrient, no. It's not ethical to have placebo. You have to keep them on whatever they're taking or the RDA. And then you add a little bit extra to see if that does anything. So you've got a much smaller dosage window with nutrients than you do for drugs. And other problems. Are you as a healthy person going to volunteer to take something whether you know it's good or not? Here's a pill. Maybe it's good, maybe not. It might be placebo. And you're going to do this for how long? Oh, that disease, let's say cancer or multiple sclerosis, might take you 10 years to detect. Are you going to take a placebo or a therapy for 10 years? And there's no graduate student wanting to wait 5 years for you to take your drug for 10 years. Doesn't happen. And also, how likely is it that you as a young, healthy person are going to take something and have a disease event like a bone fracture, cancer, heart disease, stroke? Nothing. Low probability of event. It doesn't happen. Multiple sclerosis. I don't have time to show you all the background detail, but in 2011, I was one of 20-something international researchers asked by the National Multiple Sclerosis Society of America to come to a conference whose purpose it was, can you come up with a research fundable study that could demonstrate that taking vitamin D reduces risk of MS in people who don't have it right now? MS is a horrible disease. So, conclusion, no way. We can't study whether vitamin D reduces risk of MS. Why? Do a power study. In a given year, 10 out of 100,000 people will end up with MS. Okay, you've got an event rate of 10 per 100,000 people years. It's extremely difficult. So you've got a proportion of something happening. This is using, I love this program called G-Power. It's a free program. Just look it up on the internet if you do want to do power studies. It's quite a high-level program. So you've got a control treatment group. You think that this population, 10 in 100,000, is going to end up with MS per year. How much is your randomized trial going to lower the risk of MS by? You know, okay, optimistically, turn it down by a half, maybe more, maybe less. But just reduce rate of MS in a healthy population by 50%. Okay, and you're just even going to power it to only 0.05, which is not a bad power, alpha error. Well, it turns out you crunch the numbers, you need 1 million patient years, 1 million patient years of randomized people to find out whether whether vitamin D prevents MS. It's not going to happen. And basically, you need 40,000 people. You'd have to study them for 15 years. No granting agency really gives much more than 5 years. No graduate student wants to do more than 5 years of work on a research project. It doesn't. And then, of course, you've got a healthy population. Here, take this. Oh, darn, I forgot for the last month. Oh, yeah, I think I'll take it now. Or, oh, I got a better vitamin. And, you know, people will change their minds during the study. You cannot do primary. In other words, primary means that people never had the disease before. No history of it. And then you got to see whether it prevents a disease in the future. It's not the same as a drug trial that can produce level 1 evidence. You need less level of evidence for nutrients. It doesn't happen for nutrients.